Welcome back to the deep dive. If you've ever looked into medical info about prostate health, you know it gets complex pretty fast. Today, we're focusing on one specific diagnostic tool, the prostate biopsy. And we're digging into sources about a particular method. It's the transperineal approach, or TPPBX. It was actually the first method used historically, but, well, it's often seen as secondary today. Our mission. Simple. We want to figure out why it got sidelined, what its real plus points are, especially on safety. And the big question, does it actually find cancer better than the much more common transrectal method? We're looking for those details that really matter for patients.
Yeah, and it's crucial to remember we're looking at evidence synthesized up to 2007 here. So context is key. What's really fascinating is, like you said, the transperineal route was the original way they did prostate diagnosis and even therapy, way back early 20th century stuff. But then the transrectal route, especially once ultrasound's guidance came in, well, it became the sort of clinical gold standard in the late 80s. Why? Because the data at that time seemed to show it had a higher detection rate overall.
Right, so the first method became the alternative. And today, TP is used, what, less often globally?
That's generally true, yeah.
Yeah.
The perception is sometimes that it's more invasive or just harder to do logistically.
But its supporters push back on that.
They do. They argue for much lower infection issues, better access to a specific part of the prostate or the anterior zone, and maybe even higher detection rates. And that background really sets up the core tension we're exploring, this trade-off or perceived trade-off between safety and proven efficacy. Thinking about the main advantage claimed, the TP approach, the needle goes through the perineum, right? That patch of
It's
skin.
between the scrotum and the anus, yeah. So it completely avoids the rectal wall.
Exactly. It doesn't pass through the rectum at all.
Okay, let's really unpack that safety idea then. If you skip the rectum, you skip the main source of bacteria, how big a difference does that actually make in complications, according to the literature?
It's pretty stark, actually. The TP approach consistently comes out as safe, very low morbidity overall. Because the needle isn't considered contaminated by, fecal matter, fever is really low. We're talking 0 to 1% in most reports.
Hold on, 0 to 1% for fever needing medical attention. That's incredibly low for any kind of invasive procedure. Just comparing, transrectal biopsies often have a higher baseline risk of infection, sometimes even leading to sepsis. So avoiding the rectum really seems to pay off there.
Absolutely. That difference in fever risk and consequently needing hospitalization, that's probably the biggest selling point from a safety angle. Major complications needing a hospital stay are very rare. The sources put it at 0 to 1.4%.
Okay, rare major issues. What about minor ones? Because those are often what patients notice most right after.
Right, minor things are more frequent, but they tend to sort themselves out. Mostly bleeding. We see hemospermia, that's blood in the semen, reported quite often, maybe up to 79% of patients in some studies, and hematuria, blood in the urine, up to 52%.
Those percentages sound high, 79, 52, but they resolve okay.
Yeah, exactly. They sound alarming, but they usually resolve spontaneously. Give it a few weeks, typically no extra treatment needed.
Okay, so that sets a really high bar for safety, which brings us to the crucial question. Even with that great safety profile, does TP actually find more cancer? That's the key thing, right? If it's going to potentially replace the standard.
And this is where that 2007 context is so important again. The reported detection rates for TP, they varied a lot, like 24% up to 51%. Depends heavily on who they biopsied, how many samples they took. But the critical finding, reading through that historical review, is that despite the strong safety argument, the TP approach hadn't convincingly shown, at least in the comparative studies available then, that it consistently found more cancer overall than the transrectal biopsy.
Wow. Okay, that's a really significant point. So the literature, as of 2007, was saying you gain safety, but you might not gain overall detection efficacy.
That's the gist of it, yes. Actually, some older studies using fewer cores, like just 6 TP cores, found lower detection rates than 6 TR cores, which really highlights that it's not just the route, it's the strategy. How many samples, and critically, where you take them from.
So maybe the answer isn't strictly one versus the other. Maybe it's about combining them somehow.
Well, that's where the highest yields seem to be based on these sources. The best overall diagnosis rate was actually seen when they did both. So like 12 cores via the transrectal route, targeting the back part, plus maybe 14 cores transperineally, especially for repeat biopsies. That combined approach hit diagnosis rates up to 37%. It really suggests each route gets you access to slightly different valuable areas.
Interesting. Okay, let's shift to the mechanics, because that perception of TP being more invasive might tie into how it's actually done. You mentioned there are two main techniques, and they're quite different logistically.
They are, yeah. Understanding these helps explain why TP can be seen as flexible, but also sometimes complex. First, there's the fan technique. This is generally less demanding logistically. It uses just one or maybe two skin puncture points, and all the cores are taken through that same access point, kind of fanning out the needle.
And that can be done with less intense anesthesia?
Often, yes, local anesthesia is feasible. They use a periprostatic nerve block, basically injecting numbing medicine around the prostate. Some Italian groups, for instance, routinely use this local method. And they can use something called a coaxial needle to make it even less invasive.
A coaxial needle. What does that do for the patient exactly?
Think of it like putting in a little guide tube first. Once that initial puncture is made, the outer coaxial needle stays in place. Then the smaller biopsy needle goes in and out through that guide tube for each sample. It means fewer passes through the skin itself, which should mean less pain, less trauma.
Okay, that sounds much more manageable for the patient. What about the second technique? That one sounds more involved.
It is. That's the template-guided stereotactic technique, often called a saturation biopsy. This is a much more intensive procedure. It uses a special grid, like the kind used for brachytherapy, placed against the perineum. This lets the doctor place the needle with really precise 3D control.
But that requires more infrastructure.
Definitely. To get that precision, and often a very high number of cores, sometimes up to 50, you need multiple, very specific skin punctures guided by the template. And because it's so extensive, it pretty much always needs spinal or general anesthesia, usually done in an operating room setting.
So it's reserved for more complex situations.
Typically, yes. Repeat biopsies where they really need to find something missed before, or maybe high-risk patients where maximum sampling is critical.
Right. So you've got the spectrum, from potentially an office procedure with a fan technique, maybe local anesthetic, all the way to a full OR case with the template technique. That difference alone must be a big factor in why TP isn't the universal standard.
Oh, absolutely.
Yeah.
Access to anesthesia, cost, OR time, all those practical things play a massive role in what becomes the routine clinical choice.
Okay, let's talk prep. Patient prep is always a big deal. Since the TP needle avoids the rectum, does that simplify things? No need for antibiotics or the dreaded enema?
Well, this is where theory and practice sometimes diverge a bit, according to the review. Conceptually, TP is sterile, right? Needle doesn't go through the bowel, so technically there's no high-level evidence saying everyone needs antibiotics beforehand. The advice was often just for high-risk folks, diabetics, immunosuppressed patients, people with artificial heart valves, maybe a single dose.
But in practice?
In practice, many centers back then still prescribed them routinely,
Yeah.
often for 3 days, kind of mirroring the TR protocols, just playing it safe, presumably.
Okay, playing it safe. What about the enema then? If bacteria from the rectum isn't the issue, why bother?
Ah, yeah, you'd think you could skip it, right. And biologically, for reducing bacteria at the biopsy site, it's pointless for TP. The needle path is sterile, but it's still often recommended. Why? 2 big practical reasons. 1, it makes the patient more comfortable when the ultrasound probe is in the rectum. And 2, crucially, it cleans out the area, which gives the doctor a much clearer ultrasound picture to guide the biopsy. Better image quality.
Ah, okay. So the practical benefits win out over the original sterile path rationale. That makes sense clinically. And quickly, what about blood thinners? Aspirin, warfarin?
The advice there was pretty similar to the TR biopsy guidelines, actually. Generally, don't stop them. The thinking is the risk of stopping, like having a stroke if you stop warfarin, outweighs the likely benefit of slightly less bleeding during the biopsy itself.
Right, risk versus benefit. Okay, so let's pull this all back to detection. We know TP is safe, it's flexible in technique. How do you actually maximize the chance of finding the cancer with it? How many cores and where?
Core count is absolutely critical. The old 6-core plans, just not enough. The literature was clear. Minimum of 12 cores for a first-time biopsy.
And that number changes if the prostate is bigger.
Yes, definitely. Prostate volume was flagged as the strongest predictor of finding cancer. If a man has a large prostate, say over 50 cc, you need more cores. Proportionately more to make sure you sample it thoroughly.
Okay, minimum 12, more if it's large. So now, the final piece. Location, location, location. You hinted earlier that TP gets to places TR struggles with. What are those key zones?
This is really where the TP approach shines diagnostically. Standard TR biopsy, because of the angle it comes from, mostly samples the back part of the prostate, the peripheral zone, and that's important. About 85% of non-palpable cancers are found there, so TR is good at that. The TP biopsy studies consistently show something different about the cancers they found, especially ones missed by previous TR biopsies. Up to 70% of the cancers detected only by TP were located in the anterior or front part of the prostate.
So the anterior zone is sort of the blind spot for the standard transrectal approach.
Yeah, exactly. Or at least much harder to reliably sample that way. This
Yeah.
makes the TP route really valuable, almost essential for comprehensive sampling. So the recommended plan for a first TP biopsy that minimum 12 cores absolutely must include specific targeting of the far lateral peripheral zone, sometimes called the anterior horn. The research indicated that adding samples from this specific anterior area, maybe just one core on each side, picked up an additional cancer diagnosis in around 11% of cases. It directly addresses that historical blind spot.
This has been incredibly helpful. So, summing up, transperineal biopsy is safe, particularly regarding infection. It's flexible, can be done with local or general anesthesia, fan, or template technique. And critically, it's vital for hitting that anterior zone where cancers can hide.
That's a good summary.
Right.
But remembering our 2007 source material, while TP had those clear advantages in safety and anterior access, the evidence back then hadn't definitively proven it was statistically better overall at finding cancer compared to TR. The review really underscored the need for more high-quality, probably randomized modern studies to really settle that comparison definitively.
Right. So here's a final thought for you, our listener, to mull over. We know TP has that clear edge in hitting the anterior zone, a known hiding spot, and it's safer regarding infection. If the 2007 evidence wasn't quite enough to show overall detection superiority, what specific advancements since then, maybe in imaging like MRI or fusion technology or better guidance systems, might be the key? What could finally provide that high-level evidence needed to potentially prove the TP approach superior overall? Something to think about. That wraps up this deep dive into the transperineal prostate biopsy. Thanks for joining us, and we'll see you next time.